All right, welcome back, everyone. Our next lecture can start soon. Yes. Hello, Brandon.
Hello there.
Oh, I'll make you a presenter now, and you can start with your presentation.
Okay.
We can say what.
Ready for me to begin?
Yes.
Okay. All right. Thank you so much. Thanks, Stephanie. Appreciate it. Good day, everybody. My name is Brandon Dickerman. I'm here to discuss with you pre-operative treatment planning, what I feel is a game changer for the modern dental laboratory. Just kind of jump right in and get rolling. So just to start with, first and foremost, a huge thank you to Straumann and Stephanie for setting this up for me. It's really an honor and a privilege for me to be here with you all today. This has been a 15-year journey for me with guided surgery, so not quite as long as Dr. Fakey, but nonetheless, it's been something that has been a huge part of my life for quite a while. So just a little bit about me. I'm a third-generation dental laboratory technician. My family and I own and operate a full-service dental laboratory in the United States of America, in the Boston, Massachusetts area. My grandfather started our laboratory 60 years ago this month. So he and my grandmother started it. My father, my aunt, and myself own and operate the laboratory today. I'm a certified dental technician in the United States. That's kind of our accreditation for dental technicians. It's not a requirement to be a dental technician, but it is something that we strongly urge our own technicians in-house to be involved with, to get their accreditation through that, because it allows us to kind of be an asset for our clinicians by investing in our own education and making sure that we understand what they go through on a daily basis chairside. For me personally, one of the big achievements of my career that I'm quite proud of is I am a fellow of the ITI, the International Team of Implantology. In the United States, in the U.S. section, that's a pretty rare thing. In fact, I'm one of 4 dental technicians or CDTs who are ITI fellows, and I was the first one to do that a number of years ago. So it's a great privilege for me to be involved with that organization. If you're not familiar with the ITI or you haven't got involved with them, if you're looking for a great organization for education through research-based implantology education, the ITI is a tremendous resource for that, whether on a local study club level or a national or international level with the congresses that take place annually. So strongly urge you to get involved with the ITI if you're not familiar. So the plan for the next hour is, kind of going through some different things. Why co-diagnostics? Why did I start with it? Why am I sticking with it all these years later? And what it does for me and why I feel it's a great partner for me in my laboratory. A little bit about my background, where it all started for me with guided surgery, what that looked like in the early days for us and trying to implement this technology and the trials and tribulations that we went through, especially before 3D printing existed for us. We'll talk a little bit about what we've done to kind of streamline a workflow to make, a seamless workflow for our clinicians, a nice end-to-end user experience from the data submission side all the way through, deliver that surgical guide in their office. And then, as far as what it's done for us and how we've grown our business, utilizing the technology that co-diagnostics has brought us from, innovations with synergy, which we'll talk about. If you're not familiar, it's not a new thing, but it is something I think is a big differentiator for a long time now. And kind of full arch surgical guides and what that has looked like for us. So let's just jump right in. So why co-diagnostics for me? Well, it has a long history. At this point, it's 25 years of history. When I got involved, it was out for about 10 years, purchased by Straumann from the company called IVS Solutions before, and brought to the United States. And, I looked at that as something that was important. I wanted to be involved with something that had a little bit of history. It's a newer thing in the United States at this point in time. And we wanted to get involved with the system that had a little bit of longevity, worked out a little bit of the kinks in the system. And, with that, once I got involved and we started getting ramped up, and today more than at the beginning, the flexibility of the software. What's important for us is, as a laboratory, we have to be able to work with whatever implant system comes into the laboratory And with the implant systems, more than that, what surgical kits the surgeons are working with. So being able to design custom implants, being able to design custom sleeves. Our goal is to keep it easy and work with OEM original equipment components and sleeves when we can. But sometimes we can't do that. We need to be able to design custom sleeves based on finding sleeves that work with a doctor's freehand kit if they're just looking for a pilot guide, for instance. When it comes to the guide design side, to me, this needs to be flexible. I can't be locked into how loose or tight the guide fits, how it contacts the teeth, how robust that guide is. I need to have flexibility and all that, especially with full arch guides, especially trying to figure out a bone support guide or a tissue supported guide or tooth supported. Having that flexibility, as you saw Dr. Fahey show when he did that guide design, we need to be able to adapt to this patient specific situation, and having that flexibility is huge. On the innovation side, I don't want to be involved with anything, whether it's guided surgery or any CAD system or anything in the laboratory industry that is stagnant. It needs to be constantly innovating, constantly changing, adapting to the landscape of dentistry today, and more importantly, to where things are going and being kind of a trendsetter in that. And over the years, the big innovations, obviously, 3D printed guides was a big thing for us. I'll show you in a moment. And then the synergy connectivity, which, as I said, is not new, but it is something I think is really important and underutilized, at least in my area of the world. Connecting our prosthetic design software with our guided surgery planning softwares, and having that ability, and I'll demonstrate that in a bit, is really important. On the more recent innovation side, the AI assistant is huge. Historically, with all of the guided cases that came in the laboratory, I would set them up myself. It was, fine to do so, but once you start ramping up the number of cases you do, it becomes a little bit of a challenge to manage the setup side of things with the treatment planning side. So being able to pass those responsibilities off to someone or a technician who doesn't quite understand the nuances of the biology and the implant planning side, and is able to kind of work with the software and the data was a really amazing innovation, and has really allowed us to kind of up the number of cases that we do with the same amount of individuals working on it, which is quite nice. So what I'd like to do is take a little bit of a step back into the past with me in my history in guided surgery and the different points in time that I think are important to kind of highlight with my history. So for me, it all started in 2010. At that time, Straumann had acquired Co-Diagnostics, and they were beta testing it, and they started to roll it out. And we were fortunate enough to be the first customer in North America to purchase not only Co-Diagnostics, the planning software, but we also, at the time, didn't have 3D printing, so we purchased the hardware called the Gonix table. For those of you who've been involved with guided surgery prior to maybe 2015 or so, maybe the hair on the back of your neck is standing up a little bit hearing the word Gonix again. For me, it was a wonderful success, and I'm going to kind of highlight that, but it's something that I'm quite okay with never using again, because we've kind of put the past in the past and move forward, and I'll demonstrate that shortly. In 2010, we got involved with guided surgery. It was starting to kind of be something that we felt was really important for us defining ourselves as a laboratory as part of like a niche product. But as a laboratory, our focus has always been prosthetics. And so to jump into surgical guide design was fine and important. We wanted to also be able to keep it within our world, our digital prosthetic world. And we wanted to bring in the ability to fabricate a provisional restoration pre-surgical, and utilizing the tools of Co-Diagnostics and the hardware of that Gonix table, we were able to fabricate pre-surgical provisionals, which at the time was very hard to kind of come up with a workflow. And we were innovative in that, and we were able to succeed with that. So we did that basically immediately within the first year of having the software and planning cases. 2011, for me, that was kind of my big break into the lecturing world and kind of a little bit with educating and so forth. At the time, Harvard Dental School did not have their own Co-Diagnostics planning software. They didn't have the Gonix table to fabricate the surgical guide. So I was fortunate enough to be involved with all of the planning that was done with Harvard at the time. And I owe a huge debt of gratitude to the implantology program, and specifically Dr. Herman Galucci, who was running the program at the time, because every case that was planned, I was on a conference call just like we are today, that I would drive the software and he would train his residents on, the importance of implant placement and respecting, all the biological constraints of doing so. And then in 2011, they held their first ITI Education Week, and I was invited to be a part of that. So I was able to give a lecture, do some training on co-diagnostics, and it was kind of my launch into lecturing, which was quite exciting for me to be involved. In 2012, we started to dabble a little bit with 3D printed surgical guides, but at that time, 3D printing was kind of in its infancy in dentistry. We had large batch printers, your PolyJet printers, not the smaller desktop printers we have today. They were quite large, they were quite expensive, and very unreliable. So at the time, we partnered with a company out of Florida in the United States, Cordette Advancements, who was printing at the time. So we were able to design our surgical guides, send them the STL file for them to print us the guide and send it back to us to then turn around and send it to our clinicians after placing the sleeves. And that's what we did for a number of years, because we didn't want to get involved with 3D printing at that time, because the reputation of it at that point in history was quite unreliable. And we didn't feel like at that time it was necessary to be involved. In 2013, for me, a big milestone was that I had an opportunity to travel around the United States, doing all sorts of lecturing on guided surgery at all the major meetings, all the specialty meetings for Straumann, along with doing education at lots of universities and private dental practices, training individuals on the software as well. So, that was a big point in my history in guided surgery. In 2015, we felt at this point in time, we need to get involved with 3D printing. So we acquired our first 3D printer that was purchased specifically to print surgical guides. We didn't at that time print models or anything like that. Today, obviously, we're using 3D printing for lots of different, avenues of production, from models to restorations and surgical guides and so forth. But at that time, it was bought specifically to print surgical guides. And, it started slow with printing of guides in-house. And, I feel quite proud of the fact that 10 years later, we produce on average somewhere between 1,800 and 2,000 guides, which are designed in-house and then printed here and sent out to our clinicians. But guided surgery for us, as I said, started in 2010. And I want to just kind of go through what that looked like at that time, so you can see the innovation that's taken place over the last 15 years. So it was a very slow start for us with guided surgery. It wasn't something we did daily or weekly. It was something we did, a couple times a month if we were lucky. And what that looked like was we had a device called the Gonix table that you see on your screen here that allowed us to very accurately produce a radiographic or scan appliance the patient had to wear during the CT scan, and then use that same guide to modify it to drill the guide and place the surgical sleeve in space that had to be grooving, as you'll see in a moment. And it was something that was quite cumbersome. And it's why I feel guided surgery had a slow start, at least here in the United States, because it wasn't a streamlined workflow. It started with needing to get records before the CT scan was taken. We needed to have a model, whether that be a stone model from a conventional impression, whether it be an early printed model. We had, iTero as an early, scanner that printed models for us, that we would get the model in and fabricate some sort of radiographic guide with barium or radiopaque teeth in the edentulous spaces. Then what we would do is we would mount that guide with a special plate called the template plate here, and reference markers that you can see there in our Gonix table. Take it, trim up that guide so it fit in the patient's mouth, and send it out to the clinician to have a scan taken, whether that be a CBCT scan, or at the time, a lot of cases were done with medical CT scans, as Dr. Fahey was outlining before. We get the data back, and then the first thing we did before planning the case was to align those reference pins and make sure that we could see them in the scan and they align perfectly, because that's what set up our Gonix table. And then the planning, this is an earlier version of the software, as you can see here. We would do our planning basically the same, difference being is we wouldn't be using digital diagnostic mock-ups. We would be using radiopaque teeth that were placed in the scan appliance. And then instead of outputting an STL file, we'd output a a plate that went on the Gonix table, and then an individual set of coordinates per implant that would dial in the different plates of that Gonix table to very accurately give us the position in space of where we needed to drill the guide and then place the surgical sleeves and glue them into place, as you can see here. So we glued them in utilizing some of the light cured resins available. And at the time, I felt quite proud of how long it took me to place the sleeve in the guide. I felt that was pretty efficient. I could do it in approximately 7 minutes. And what that meant was setting the Gonix table, drilling the guide, placing the sleeve in, having it checked because we wanted to have a second set of eyes on it. So you can see why this was not something that was well adopted. It took a lot of labor in the laboratory just on time to get to the point that we could produce a surgical guide. So that's where we started with guided surgery. It worked. It was very accurate. It did require jumping through several hoops on the appointment side. It sometimes was 4 or 5 appointments to get through surgery, and it wasn't something that was well adopted for that reason. It was everyone's trying to make their office more efficient, and here we are implementing something that's going to make them more accurate, but it's going to increase the chair time to get there. So it didn't really take off. So once 3D printing got kind of into the fold and was mainstream, we started to look at how we could streamline our workflow as far as an end-to-end solution that made it easy to utilize this technology for our clinicians. And it starts with the case submission. Most of what I see in my laboratory are not cases that are planned by clinicians in their own co-diagnostics software. They're cases that I'm planning in conjunction with them utilizing my software. Whether they have the software and we send it to them for putting up in the operatory during surgery, or just for their records, or a little tweaking here and there. Most of what's done, at least with me, is planned by myself and the clinician together. And it starts with getting the case to us. And so we wanted to do what we could to streamline that case submission, to make the online treatment planning as efficient as possible. Everything that we do with the clinician. I never plan a case without them. Everything's done online together. And then we use a system that they actually DocuSign a digital signature onto the PDF of the workup that we export out of Co-Diagnostics to confirm that we have the green light to use the surgical guide. And then within 2 days, we'll have the guide in their office. So we've tried to streamline that to break down the barriers of utilizing this technology. So with file submission, we started out trying to kind of work within everyone's system. We didn't want to force anyone down an avenue that they had to go down to work with us. So we started by making a HIPAA-compliant file transfer portal on our website. So we have an uploader on our website that you can go fill out a form and upload the case to. It worked pretty well. We receive intraoral scans through the intraoral scanning portals, which works fine. We do that, as I'll show you in a minute, every single day, and manage lots of portals. And then on the other way of uploading cases, the file transfer portals that are out there, Dropbox, WeTransfer, Google Drive, SmileCloud, Hightail, etc. The problem is we need to make sure that we're protecting the patient's privacy. In the United States, we have something called HIPAA, which I can't speak to all over the world, but I'm sure it's similar if it's not the same thing. So we need to make sure that if you are using a file transfer portal, it is HIPAA compliant. For instance, SmileCloud is. Certain versions of Dropbox are if you pay for them, but free versions are not. WeTransfer is not. So you need to be really careful about protecting the patient's privacy. So question, if you're using one of these file transfer portals, question whether or not it is HIPAA compliant. So we need to kind of make sure we're protecting that data for our patients. And on the intraoral scanner side, we receive intraoral scans from lots of portals. So we monitor on a daily basis 3Shapes portal, iTero, Medit, Dentsply Sirona, Dexis, all these portals, CS Connect, the Access portal. We have to monitor all these portals and make sure we don't have things that kind of fall through the cracks. And, the reality of it all is that we're getting data in what should be a more streamlined approach being digital, but a lot of times we forget that things are coming from different places and they can be lost in cyberspace. It happens, unfortunately, more than we care to admit, that someone uploads a file and doesn't realize that it's kind of just going off into the world, and we don't, follow up to make sure that that data came through. So we tried to find a better way, a more streamlined way to make sure that things did not fall through the cracks. And that started for us a couple of years ago, that we were looking for a better solution. So what we did was we did a little research and decided we were going to create a guided surgery submission portal. And the first time that someone works with us, we have to set them up on this. They have their own login for that portal. And we're using a program called Smart Vault, which you can all utilize yourself. And it comes with the ability to create this form here. So we made this custom RX form, or a prescription, that the patient name, doctor name, treatment plan, due date, all that has to be filled out. What implant system they're using. Are they using conventional impressions or digital? If they are using digital, what scanner are they using? The doctor ID, doctor signature, and so forth. And then once they submit it, I get an email on my end. A copy of this goes into their login on their portal. So there's always a record of it, so they know that they actually submitted a prescription for the case. And then once they've submitted that, they can go back to the website, log into the guided surgery portal, and here they can upload their CBCT scan, photos. If they're not using an intraoral scanner portal, they can upload the STL files here, whatever they need to do. And everything will be housed here indefinitely. Don't remove anything from here. So this allows the clinician to know that they actually upload the scans. They can see that they're present on the login. They can make sure that they did everything correctly. They can look at the prescription, make sure that was done correctly. And then once the case is submitted, this is what the submission form looks like on my end. So now I know that everything is there, which is quite nice. Once we finish our treatment planning, we upload, as I said, a DocuSign PDF to this login. They get an email just to click and sign here, which will always be housed there as well. So they can always view that PDF and download it if they want to, print it out and put it on the operatory walls, although we include that with the case as well. As I said, every case that we don't do with screenshots. We do with an online collaboration with the clinician. Just like we're doing today, we do a little webinar. It's important to me for a couple of reasons to do this. First and foremost, I'm not a dentist. I'm a dental technician. So I need to make sure that the clinician who is actually holding the handpiece with the drill on the end, drilling into a patient's mouth, has the final say. And it's not just quickly looking at a piece of paper in their office. I want them to look at it with me. I want to go over the things that I noticed prosthetically, notice surgically, point it out to them so that we're all on the same page. There's no surprises and there's no mistakes that can take place. So we always do this. And all the setup work that we do in the laboratory ahead of time, when we get on a conference call, whether it's a single tooth or a full arch, we can do it very efficiently. Matter of minutes or sometimes a little longer for more complex case. And I want to kind of make that an easy thing to do, whether it's at the beginning of the day, on your lunch break, or the end of the day. We always do this, and it's a really important thing as a planning center and not the clinician himself or herself to do it this way. Just as a note about kind of my setup, Dr. Fahey kind of stole my thunder. It might make me chuckle a little bit. This is what my desk essentially looks like here. I have the mouse on the right, the keyboard in the middle, and then this 3D mouse on the left. He touched upon this as something that he uses, and it made me laugh because it's something that I had in my presentation because it's extremely valuable to me. In fact, I have one on my desk and I have another one in my bag, so if I'm on the road, I can plan cases with it. I think the 3D mouse is such a game changer when it comes to any sort of CAD design. It allows us to very easily and seamlessly move images around. You can see them just hovering over the different windows and using the 3D mouse to zoom in and out. What's nice is that we can rotate our 3D image around without having to use the move and turn feature. We can stay in the positioning mode, so I can move the image and change the implant with the regular mouse all seamlessly without having to fumble around on the different buttons or the keyboard shortcuts in order to go back and forth. It really is an amazing tool. I will say there's a bit of a steep learning curve. It may take you a little bit to get used to. You can change the speed of it, but once you're used to it, you can't live without it. And all of our designers in-house, or whether it's just guided surgery or for CAD design, all have the 3D mouse on their bench to work with. We feel that it's very valuable to make things efficient once they get used to it. So thinking about this presentation and kind of what guided surgery has meant for me in my business, I didn't quite realize until thinking about doing this kind of the impact that guided surgery has had on our business as a whole. And I do really believe that it's created opportunities for us that we didn't have before and may have eventually kind of fumbled into, but it wouldn't have been as seamless to. So as a laboratory making restorations, for the most part, my relationship is with restorative dentists, general dentists, prosthodontists, etc. But I don't have a lot of relationships with specialists when it comes to making restorations. So when we came to guided surgery, all of a sudden we're opening up an opportunity to work with surgeons. We have this ability to be involved with designing of implant placement and surgical guides. And it gave me an additional revenue stream. It gave me another opportunity to grow my business with a different set of individuals, being the surgical specialists, that was kind of an untapped market. I hate to put it that way, if you will, but the reality was now all of a sudden I had the ability to work with surgical specialists that I never did before, which was quite amazing. And more than just working with them, it gave me access to their referral network, which I may or may not have known the referring dentist before. So I'm now expanding my horizons with lots of new clinicians who are of like mind trying to do comprehensive treatment planning. And it really did make us as a laboratory an integral member of the treatment team. As I said, my grandfather started a laboratory 60 years ago. And in the early days for him, before he had his laboratory, he worked for a world-renowned prosthodontist who wanted to bring him to one of the universities in town to kind of help educate him to a lecture. And he tried to bring him to the lecture, and unfortunately for him, the university said, thanks, but no thanks. No technicians need to be here. This is for clinicians only. And it's amazing to see how far we've come. Now as clinicians, as technicians, we all kind of have a seat at the table with this preoperative planning because we all have the same goal in mind: patient care, and the value that the technician can bring to that, even before the implant is placed, is huge. So that goes from single tooth all the way to full arch. And when it came to full arch cases, back to creating opportunities, the full arch revolution in the United States has been kind of this pro arch or all on X or all on full, whatever you want to call it, hybrids that have been done in the last decade, which we've been a big part of. And although we would have gotten involved with that at some point, when it came to full arch, all of a sudden we were, very much in bed with the surgeons already utilizing guided surgery. And when it came to them looking to start doing denture conversions for immediate load cases, they already had a relationship with us. So we're already involved with them in one area. And now they got us involved with full arch, which was, something that was seamless and easy to do. We have that great relationship already. And it really did allow us to, make sure that we could either whether on a single tooth side or a full arch side, kind of help with the preoperative planning, make sure we're planning the cases, looking at that true prosthetically driven crown down approach, and giving the end result being the restoration, the best shot at success. And it really gave us an amazing opportunity to fabricate pre-surgical provisional restorations that kind of helps the surgeon differentiate themselves from someone down the street, that they can deliver to the patient, deliver to the restorative doctor a provisional before the day of surgery or on the day of surgery, excuse me. And the other thing that, was really great for building bonds and relationships through guided surgery was involvement in study clubs. Yes, we could go there and we could, help with our expertise of prosthetics, but now I bring my laptop to a study club meeting. We can load a CT scan, we can evaluate the bone, we can evaluate the restoration, all of the things that we know from treatment planning, utilizing, guided surgery. So it really does make the laboratory technician, if they're involved with this, an integral member of the team, and something that, I didn't quite give guided surgery its due, if you will, before putting this lecture together and realizing what it did for us as a laboratory. So I want to shift gears a little bit. I want to talk about, kind of preoperative treatment planning and fabrication of restorations that we utilize on the day of surgery. And, a number of years ago, this isn't something new, but a number of years ago, Straumann came out with this technology and this technique called synergy. And what synergy is essentially, it's the real-time connectivity between our CAD design software, which is called CARES Visual, and Co-Diagnostics being their guided surgery planning software. And what it does for us is it allows us to design a pre-surgical provisional restoration, whether it be a custom healing abutment or a full contour provisional, utilizing stock abutments, all done digitally, all done prior to the day of surgery. And it allows us to design our future tooth position based on and our implant position based on a fully digital wax up that is a little bit different than just importing an STL of a wax up or importing the STL of a model that we scanned of a wax up, because what we're able to do is modify that wax up in real time. So what Straumann did, which was quite clever, was they put all of their software engineers for the two systems under one roof, allowing them to kind of collaborate and create a system that has real-time connectivity between these two technologies. So co-diagnostics, as you can see here, and then CARES Visual. And when you put those together, you end up with this technology called Synergy. Now, the nice thing about co-diagnostics today, if you're not utilizing CARES and you want to still be able to fabricate a provisional, in co-diagnostics, as you may or may not be aware, you can export a implant analog model, or you can export a scan body model, an STL file that you can import into your CAD design software. So you can use, a different design software, ExoCAD or Shape, whatever you want to use to fabricate a provisional. But if you want to be able to modify things on the fly in real time, we have this ability, which is really cool. So I'm going to give you a little demonstration of that in real time, just kind of sped up a little bit. So we'll have CARES on the left, we'll have co-diagnostics on the right. So we start by obviously loading our CBCT and co-diagnostics, and then in CARES, we'll load up our STL files of our models or intraoral scans. And then what we're doing is our digital diagnostic mock-up, or wax-up, if you will. Our goal here is not worrying about the subgingival contours at this point. Our goal is to get the rough shape and size of these teeth and size of lid position, cingula, and so forth, kind of aligned for a planning phase. Once we get the rough position where we're happy, we'll use their server, which is HIPAA compliant, to send that over to co-diagnostics, and then we merge together our STL like we always do. The big difference here is not only we bring in the soft tissue model with the teeth, we're also bringing in that wax up. And the wax up is actually able to be moved and modified in real time. So you'll see here, as soon as we put an implant, our CAD design software recognizes that there's an implant in place and asks us to kind of select a abutment for that. So we'll pick a variable-based abutment that we're going to use. We drop that in, and what you'll notice is as we modify our implant position in co-diagnostics, in CARES, our implant's going to move. And she allows us to see how that relates to our tooth position, which is pretty valuable for us. If we have a prosthetist on the phone who wants to modify our wax up based on what we see in the bone, we can do that in real time instead of rescheduling the call or he's redoing the wax up, et cetera, et cetera. Once we kind of finalize our implant position, we'll lock those implants so we can't make a mistake. We go to our CARES visual design software here, and now you'll notice that as we modify the subgingival contours of this restoration, or the tooth as a whole, whatever we need to do here, you'll see that in co-diagnostics. So if the clinician has their own software, being co-diagnostics, they can see co-diagnostics live in their operatory or their office, and we can do this in the laboratory, which is pretty neat for collaboration. So we're able to design these restorations in real time and make the changes we need to make, which is quite cool. So you can see here, we're fine-tuning the shape of our provisional. We want either a flat or concave emergence profile out of the bone and the soft tissue. And we finalize the design of the restoration. We finalize the design of our implants. We're all here because we're users of co-diagnostics, so I'm not going to spend a lot of time on surgical guide design, but I'm just going to let this run and point out a few things about my preferences with designs. So as a laboratory, I'm sending guides out all over the US that need to be able to survive shipping and so forth. So I try to make sure that my guides are robust. Part of that is a full arch guide. I want the guide to be cross arch stabilized so the clinician can't accidentally torque it and change the long axis of his drilling. I make the guides on the thicker side unless the surgeon has a problem with that, because once again, they need to survive shipping. I want to make sure that they can see that the guide is seated all the way. So I put a minimum 3, but typically 4+ windows in that so they can visually see that we're seated on the cusps of the teeth. I think that's really important. And then for me, my preference when it comes to placing the sleeves in a guide is I don't like to press fit the sleeves. I don't want to take the chance of, weakening or putting some sort of microfracture in the guide that I don't see, and they ship it out. We ship it, and they maybe autoclave it and it breaks. So I want to make sure the guide is strong. So we actually lute our sleeves in utilizing some of the resin from the 3D printed guide, the same resin, just out of a syringe. We lute it in place. So we have to make sure the offset's appropriate. If you're not familiar with how to check the offsets to kind of calibrate the software to your printer, to your sleeves, in Co-Diagnostics, when you go through the Guide Design Wizard, you can click on this tool here to change the offset of your sleeve as far as how loose or tight the sleeve fits in the guide. But what is more helpful is to actually take that calibration jig, and you can print that matrix out. So you can see what it looks like here. We can print this out. It has all the numbers on the side. You can do this for every sleeve, different configurations, whether it's a sleeve you buy from Straumann or a third-party sleeve, and you want to see how loose or tight they fit. And you try the sleeve in this grid, and then you can set the software so it defaults to that every time. Just something that I find is quite helpful. So when it comes to immediacy, we have some options available to us. We have to look at what do we want to do here. I mean, the goal ultimately is to give the patient, if we're talking about an immediate implant, the ability to maintain their soft tissue architecture, to start to sculpt the tissue if we're going to change it, but not to have the tissue remodel unnecessarily or in a way that we don't want. So we have two options here. We can fabricate a custom healing abutment so that we at least start to have something that's a little more anatomically correct subgingivally, or we can fabricate a full contour provisional restoration. Now, a lot of times we don't fabricate the full contour provisionals because we're trying to play the long game here. We want to make sure the implants are going to be stable through the integration phase and then last long term. And if we have a patient that we are concerned about the available bone that we're going to anchor the implant in, or we're concerned about compliance of the patient, that they're not going to listen to the restrictions, we need to make sure that our patients are going to be protecting their implant long term. So we might give them the first option being custom healing abutment. So this is what that looks like essentially. So this patient had horizontal root fracture. We place our implant in the software. We design our provisional restoration being custom healing abutment to have a flat or under-contoured emergence coming out of the soft tissue. The goal here, where subcrestally placed, is to stay within the confines of the bone, emerge the soft tissue, and then protect the existing gingival margin. So here it is in cross-section, the tooth that came out. The implant is then placed, and then our custom healing abutment goes in. And this can be modified by the clinician once they place it based on if it's a little too high supergingivally. So here it is here from the planning to the execution of the placement of that custom healing abutment. And as I said, if they want to put an Essex in, they could sculpt this out a little bit more. We do mill it out of a pink material. The goal is that it doesn't look like a fractured off tooth. It just looks like it's part of the gums at first glance. With the Synergy protocol, we can utilize this, as I said, for a custom healing abutment. We can utilize this for a full contour provisional restoration. So this is, if you see here, a young patient that came in, and unfortunately they had an accident, and they have a horizontal root fracture on number 10. So the goal here isn't to modify anything as far as the soft tissue is concerned. We want to give the patient back what they walked in the door, just replacing it with something more stable long term. So here's how the patient presents, and you can see here they have a fairly large, tooth that was there. It's fractured off. We're able to place a 3.3 by 10, slightly subcrestal, get some apical anchorage there. The periodontist working on the case felt that they'd get the primary stability that they needed, and this is how we plan the case. Here's our planning phase. We have our intraoral scan overlaid before the tooth is extracted. Then we can virtually extract that tooth using some of the mesh editor features in Co-Diagnostics, which is great. You can see this is the, this is the provisional that we have designed here. And it's basically, in this case, looks just like the tooth that was in there before. We didn't modify it in any way. We want to give them the tooth back. The only difference is once it's inserted, they're going to level off the incisal edge to really make sure they take it out of occlusion. And as I said before, my preference on a surgical guide, unless there's a reason or the clinician prefers, a small quadrant guide, is I like a full arch guide. I like a guide that's stabilized cross arch so that when the drill is in that sleeve, accidentally torquing that drill won't dislodge the guide without anybody noticing. It allows it to seat really well. Now, obviously, based on the case, this can be quite challenging if the teeth are very divergent to get that seated. And if that's the case, maybe we'll shorten the arch. And I can understand those constraints. And we always look at the case by case. And based on how loose or tight we want the guide to fit, based on that, we'll modify those settings and co-diagnostics as well. When we design our provisional restoration, the subgingival contours are extremely important. Obviously, we want it to look like a tooth when it comes to from the tissue down to the incisal edge, but designing those subgingival contours to protect our soft tissue is really important. If we make our restoration so it's over-contoured or convex, as you can see here, then what's going to happen is it's going to push the soft tissue apically and reposition it maybe where we don't want it to be. Our goal here is to kind of preserve the soft tissue. Even if we want to play with that level, we do want to slightly modify it to make the tooth a little longer, but we don't want to change too much too fast. So we make our restoration so it's under contoured, so the soft tissue just kind of sits right on that restoration like that, and it doesn't want to apically reposition while we're kind of in that integration phase. And then depending on your preference, depending on your equipment, what you have, whether it be in your dental clinic, whether it be in the laboratory, you can either mill or print the provision. Our goal is to give something that's as aesthetic as possible. And today we feel that without having to jump through too many hoops, because we have the technology in-house, we mill our provisional restorations. The milling time is fairly quick. We're able to mill out of a puck that has some shape gradient in it. So you have some incisal and body in that puck, and we can kind of set the tooth in the puck accordingly. And then what we do is we work with a stock component. So this is a vario-base abutment. And so what you see here are the 4 engaging cams of that vario-base that are engaged into the milled part. So we haven't even removed it from the puck yet, but I wanted to see how it's seated. So that's what that looks like there. And then here's what that component looks like. And as a laboratory, my stance on making restorations is to have as few areas for complications as possible. So if at all possible, I try to stick within the OEM realm. And that starts right here with the provisional. So the tie base that we're using is actually a vario-base abutment. You can see that laser etched into the side of that there. And then this is it luted together. And then what we do as a laboratory, because I'm not the clinic, I'm not the clinician working on the case, I'm sending out the guide, I'm sending out the provisional. I want to make sure that the surgeon has the ability to confirm the accuracy of the surgical guide. I always print a model. Now this model was printed on the Straumann P30 printer here, as you can see, and we print the surgical guide out of the resin as well. This is the previous iteration of that resin that was an amber brown color that when autoclaved, it actually change color and become a little more translucent, but we always print out of a dimensionally stable autoclavable resin. So you can see the surgical guide, and this is what we send in our package to our clinician. So they get the model to test fit the guide if they're struggling, they have the surgical guide, and then they have the restoration as well. So here we are, they place the implant utilizing the guide, they graft the buccal plate. The rotation of that implant is super critical. They need to make sure they place that so that the incisal edge, the contact, everything is aligned perfectly. And utilizing the whatever transfer piece, whether it be a Loxa mount on the BLT or the transfer mount for BLX or BLC, they need to align those dimples to the buccal. And you can see here, they've taken the incisal edge way out of occlusion, but ultimately the goal here is to give the patient a tooth and maintain that soft tissue architecture. We don't want the papilla is moving on us. We don't want that CEJ position to kind of change unless we want to play with that later. So the last case I'm going to talk about with Synergy is a case that I think really illustrates the power of preoperative treatment planning, interdisciplinary treatment planning, etc. Because the goal here is more than just site number 7 or the lateral incisor, or forgive me, but I think it's 1, 2 in the federal the international numbering system. And the goal here is to place this implant and make sure that we're modifying the soft tissue at the time of placement, grafting that soft tissue, so that we can set the case up to do some kind of aesthetic dentistry and give the patient a beautiful smile in the end. So this is how the patient presented to the periodontist. And the goal here is extract this tooth, place an implant, and in the end, do restorations to give the patient an aesthetic result beyond just number 7. So we go to our planning software. You can see here we are in Co-Diagnostics. This being a lateral incisor, typically we're looking at a smaller diameter implant, like a 3.3 or a 3.5 diameter implant, but this particular site was very large. From mesodistal perspective, buccal-palatally, we had a huge amount of bone volume. The emergence profile of the restoration, we could get away with an RC implant. So this was a 4.1 diameter implant, but based on the site and trying to get primary stability, we went with a 12 millimeter length to get apical anchorage. So you can kind of see the planning that was done. You can see we're using every bit of height of bone to get some good anchorage in the bone apically. So here's our planning mock-up. Here's our implant position. We're able to engage the walls mesially, distally, and palatally. Obviously, on the buccal plate, that's going to require some augmentation at the time of placement. And then we go to Cares Visual to do our mock-up. Now, when we do the final design of the provisional, we need to think about the fact that we're going to do a connective tissue graft, and we want to reposition the CEJ of that tooth, the gingival margin, so it's a little less apically positioned, so it's more coronally positioned. So when we design this, we need to keep that in mind. We planned for a screw retain restoration, as you can see here. And then what we ended up doing was taking and making this restoration. So you can see the emergence of the very base abutment and kind of protecting our tissue graft that's going to be done. So here's the design of our provisional. They did their grafting. They harvest the tissue from the palate. In this instance here, implant is placed. Once again, the timing of that implant is extremely critical. Then they'll go ahead, they'll do the tissue graft, and then deliver the case. So here's the results, pre-op, post-op, and then the day of surgery. So patient's obviously a little bit numb still on the day of. And here we are 5 days post-op, and you can kind of see the tissue healing and healing around our provisional. Here we are at 2 weeks, and the tissue is starting to heal quite nicely. And then here we are at 6 months. So looking at this, obviously, we haven't done the restorations yet. And is this a perfect result? No. I mean, we could sit here and nitpick, the pillows aren't perfect, et cetera, et cetera. But overall, thinking about this case, if we did not take the time to manage the soft tissue at the time of placement, it would have really affected our ability in the end to give us a nice result. So pre-op, post-op, and then actually 2-year post-op radiographs for you. And then here it is at the 2-year post-op after the restorations have been done. So looking at what you see on the screen here, if we did not take the time and care as a team to plan the case and make sure preoperatively we plan the implant depth, we plan the emergence profile the way that we needed to, we may not have been able to create the gingival harmony that we needed here. So you imagine here, if we didn't do that, where the gingival margin of the restoration would be. And then in the end, it would not be a fairly aesthetic result. And as I said, is there things we could have done differently? Maybe made it a little more perfect? Of course, we can pick that and get to that pretty easily. But if we did not take the time to at least do what we did, it would have been a very different result for us. So, Synergy is a tremendously valuable tool, and it does come with challenges. And I want to make sure that, I kind of go through that, because I feel like with any presentation, just showing, this went great, is all well and good. But, what you and I really want to see and make sure we go in with our eyes open is, what does it really look like? What is the challenges of a case? And what are the challenges of this workflow? Big challenges that can take place are on the surgical side, on the communication side, because now we're dealing with surgical and restorative and lab all at once, and the restorative office as well. Like, what do these challenges look like on a case? So let's kind of go through that. Obviously, for the placement of an implant surgically, the implant rotation has to be placed rotationally perfectly. So on a Straumann implant specifically, depending on the implant, the transfer piece that's utilized has dimples on it that correlate to the connection in the implant. So the rotation of that needs to be lined up with the dimples to the buccal. In co-diagnostics, when you do a guide design, you can actually put markings for rotation on the guide so that they align those dimples to where those markings are, so that everything lines up in your restoration that we make, which is an engaging restoration, aligns with the contacts correct, with the incisal edge correct, and so forth. Implant stability is obviously extremely important for loading an implant. Excuse me. Selecting the proper size of the implant and type of implant is the name of the game. What that magic number is for you as a surgeon is the personal preference. Is it 35? Is it 45 Newton centimeters? More? Is it less than that? I can't sit here and tell you what has to be done. I'm just telling you that you need to make sure that whatever implant you use achieves that magic number. Whether it's a more traditional BLT implant, as you saw in the previous case, whether it's something more aggressive that we have available to us, like a BLX or a BLC implant, whatever you're using, we want to make sure that we get good primary stability so that we can load the case. On the communication side of things, learn from my mistakes. We all make mistakes. Some of us make some and don't want to share them. I want to make sure that you learn from the mistakes that I made. So here we are. I made a custom healing abutment for this case. We planned the case, the periodontist and myself, and I didn't do a very good job during the treatment planning phase of communicating to the surgeon what I saw. And it's more than just looking at the bone. We're looking at a lateral incisor here. We can see that there's a tissue defect. The bone seems to be fine. We can place the implant. Maybe crestlet is a little bit there that could be grafted, or the implant could have been placed a little deeper. But ultimately, I should have looked at this soft tissue and said to the periodontist, are you planning on doing anything as far as a tissue graft is concerned? Grafting or building out that tissue or building out the bone in the tissue, whatever it is, are you planning on doing anything? And I didn't. And the periodontist didn't tell me what he was doing either. So we failed on both accounts. So I get a photo and an email, and the subject of the email is, what happened? And I open it up and I get a photo that looks like this. And now I'm looking at this going, what did I do? Wow, why did I under contour that custom healing abutment so much? So I go back to the planning and I look at the image that you see on the left, and I'm like, I kind of think I did a good job. And I start going through the notes of the case and the prescription. And then I emailed him back. I said, did you craft the case? Because I have no notations that you planned on doing that. So it was a failure on my end because I didn't communicate what I saw. It was a failure on his end because he didn't say, yes, I plan on doing the tissue augmentation and building that out. And so now we fabricated a custom healing abutment that didn't do anything for us, no better than a stock abutment. And we want to, kind of get that gingival margin out more labially so that we have a nicer emergence. So it defeated the purpose, and it was a waste of everybody's time and money to fabricate this custom healing abutment. On the restorative side, there are challenges. A lot of times in the United States, the restorative doctors aren't necessarily placing the implants, and they're referring them out to a periodontist or an oral surgeon to do the case. And if they do that, they're not necessarily thinking about an immediate implant and immediately loading that implant. So shade is always kind of one of these things that's forgotten about. Once it gets in the hands of the surgeon, they're not wired towards taking shades. So I called up the restorative doctor. I say, what shade are we utilizing for the restoration? They said, I don't know, E2 or A3. Well, give me a shade. Tell me specifically what you want and take shade tab photos. Don't just take a retraction photo like this, because this does nothing for me when it comes to shade selection. Give me, a little more information to go off of to try to get something that is correct. I will say that the thing that goes wrong the most with our cases with Synergy is the shades off. Usually ends up, we're just guessing at something like A1, A2, something like that, and it doesn't end up matching what's going on in the patient's mouth today. So that's important to kind of note. Not a failure of the case, just doesn't give us the exact result we'd like. Once the implants are going in, who's going to be placing the provisionals and who's going to be torquing them in as far as the day of surgery? Whose responsibility is that? The very first Synergy case that I was involved with should have been a slam dunk. We were planning two single centrals. They looked like they were in good bone. They were not immediates, but they looked like they were going to be in pretty good bone. The periodontist did some tissue grafting. His plan was to place the provisionals, get them seated, graft, close everything up, and send the patient over to the restorative doctor, who was going to torque the provisionals in place and then equilibrate them and seal the access holes. So he put them in, just kind of finger tight, sent the patient over in the afternoon to the restorative doctor, who looked at the patient, did a little equilibration, said, "You look great," covered the access holes, and called it a day. So the provisionals were never torqued. They were just finger tight. Unfortunately, the patient also failed us here. The restorations got loose. And instead of calling up the dentist and saying, "My restorations are loose, you want them to come in," they didn't say anything. And now we have 2 loose restorations during integration. What ended up happening was both implants failed and took the buccal bone with it. So now it made a very easy, seamless workflow and made it quite complicated and a problem. So that's enough on the synergy side of things. So just to briefly talk about full arch, in today's, dentistry, that's kind of all the buzz. That's what we're talking about on all the podiums and all the meetings. So I'm not going to spend a lot of time on that. But on full arch treatment, once again, going back to, why is preoperative planning, why is guided surgery a huge, important factor for us in our laboratory, and a game changer for us, is I do believe that gave us, a jump start into the full arch world and doing full arch cases. My father and I both go out to clinicians' office and do denture conversions on a daily basis. We do roughly 200 full arch cases a year. Not all of them are guided. All of them get a guided surgery plan, but they're not all done as far as surgical guides. But I do owe all of that, as far as getting involved with our surgeons at the beginning, to guided surgery. I think that was a huge factor in how we kind of got involved with it pretty early. So, full arch is a really important part. The type of surgical guides that we fabricate for our clinicians is a personal preference on the clinician side. What do they like? Do they want a stackable surgical guide workflow utilizing a fixation pin guide that's probably a tooth point guide, a reduction or bone reduction guide that's a foundation guide with a tooth-borne surgical guide and a stackable prosthesis? Do they want something different, like a sequential guide? Sequential guide being, a tooth-borne reduction guide, and then a tooth-borne, potentially, implant placement guide, or a pin-borne implant placement, osteotomy placement guide. And that could be a fully guided case or a pilot guide. And it's based on what their preference is. It's not about me. But just to kind of show you what that looks like in the 2 different workflows, here's a stackable guide case, and this is the preoperative situation here. Our first guide, our pin-borne guide, sits on all the teeth prior to extractions and is pinned into the bone, or drilled into the bone. This allows the surgeon to get those pin positions in a precise location based on merging the STL file of the teeth with the CT scan. Once that's drilled, teeth are extracted, flap is reflected, and then our fixation pin bone reduction guide goes in. Now this guide is super critical to get in the right position, because this is going to make or break the entire case. The guide has to go in. You have to find those fixation pin holes, which isn't necessarily the easiest thing to do. But once the tissue is reflected far enough, you can seat that guide. My guides typically are just on the buccal plate. They don't go over the ridge against the palate, because I don't want to make it so they have to reflect even further at the palate. Then the next guide that goes in, that stacks on top, is our implant osteotomy and placement guide that you can see here, which we modify after it comes out of Co-Diagnostics. And then our provisional that we design in our exocad design software, bring into Co-Diagnostics to put the legs on it and put the holes in it. So this is an option for our clinicians. Now, I think that it works when everything is done really well. But to me, this is something that we need to be extremely careful with, because if they don't get that first guide in, our long axis of our implants are off. The access hole positions are misaligned. The prosthesis has a cantonate. All of these factors can really affect everything downstream. So seating that guide is really critical and can take quite a bit of time to make sure it's done correctly. So it's a preference thing if you like this workflow or not. It's something we do offer to our clinicians, and this is how our patient leaves the day of surgery. The workflow that I find is in my neck of the woods, or my part of the world, that is more well accepted at minimum, even if the case isn't going to be done guided, just the planning, I can always get a surgeon to agree to a guided bone reduction guide. So this is a guide that I fabricate that sits on the teeth. The edge of the guide, think of it like the the flange, if you will, of that guide is our bone reduction plane that they can take their burr and they can literally score the buccal plate. So at minimum, we get the amount of bone reduction based on what our workup is. Even if we don't move forward with fabricating a guide, as far as a guided surgical guide, we at least get the reduction guided, because that is a hugely important part of that full arch workflow. Sure. So here's our guided case. This particular surgeon wants a pilot guide. Total preference, that has nothing to do with me, whenever they want. But this gives them a little more flexibility if they go after extractions and find that things aren't quite where they want them to be bone-wise. And then we'll fabricate. This was done with an ICAM workflow utilizing photogrammetry. So we print our provisional direct to MUA, and then here's the patient, pre-op, and then the day of surgery, which in this case was actually the day after surgery for delivery. Moving forward with the case, when we do our cases full arch, we always do them on an integrated bar. We utilize with Straumann their core bar. So this is the core bar file from photogrammetry from our ICAM, and then this is our zirconia overlay on the bar there, as you can see here. So we always support the zirconia with titanium. So kind of pros and cons for what we see in our world with full arch guided. It gives obviously a little more control over the reduction based on where the CT workup is. It's not just prosthetic reduction on a duplicate denture with the reduction marks put in. Once the guides are seated, obviously the drilling protocol is super fast. We don't have to worry about taking x-rays or scalp films in the middle of surgery to make sure we're not hitting the sinus or the nerve. We're not concerned about that because we've worked all that out ahead of time. And then we obviously can look at our restoration ahead of time and predetermine our restorative components. Kind of the cons that I see are with a stackable workflow, that foundation guide has to be perfect. If not, everything's going to be off. And that really is something that I make sure I spend a lot of time getting the surgeons to understand is they have to spend the time to get this perfect, because everything goes off downstream from there. And it's a very restrictive protocol. So if they go and extract all the teeth on a fully dentate patient that is a terminal dentition state, maybe they end up taking more buccal plate on some of the sites than they anticipated. I mean, we didn't see that in the workup. And now all of a sudden, we have to make a pivot in surgery, and then you have to find a new site. Now all of a sudden, we have a restoration that we have to move the holes in, but we've already drilled those holes digitally in co-diagnostics, and now we weaken the restoration because we've taken more of that material. Full arch obviously is a huge part of what we do, and incorporating aspects of guided surgery into that is something that I find tremendously important. Sometimes we do it fully guided, and sometimes we just partially guide that. And it's based on the surgeon's preferences, and obviously how the patient presents as far as dentition plays a role in what we can do as well. So I appreciate your time, and I just want to kind of wrap things up with you. The big take homes I hope that you get out of this, if you're a laboratory specifically, are if you're trying to utilize guided surgery to give yourself a differentiator, to make yourself a more integral member of the team, it really needs to be a streamlined user experience for the end user, who's the clinician, the surgeon, the restorative doctor who's involved, whatever the case may be. It needs to be streamlined. It has to be easy to work with you. They don't want to have a cumbersome workflow to get a surgical guide in hand. They don't want it to take too much time. It needs to be easy. It needs to be consistent every single time. For me, guided surgery has created tremendous opportunities across the board, whether it be from single tooth to full arch, whether it be provisionalization or even introduction to full arch cases and study clubs. Guided surgery, I feel I owe a huge debt of gratitude to kind of creating those opportunities for my laboratory. It allows us to offer different immediacy options in this world. That's what patients want, and I'm sure around the world and wherever you are, that's no different. Patients want to replace a failing tooth with an implant and a restoration the same day. And if we can do that with guided surgery, that's great. Full arch is no exception to that. Failing teeth come out, implants go in. That's not good enough. They want the implants in, and they want a fixed restoration if at all possible. And guided surgery can aid that. And then obviously we looked at the way that we do our full arch guide designs. And it's a little different based on the clinician, but all goes back to why co-diagnostics, because it gives me that flexibility. I can do whatever I need to do to make the clinicians happy at the end of the day, utilizing the software, and I'm tremendously grateful to have been involved with it for the last 15 years. And with that, I do really appreciate your time. I hope that there was a pearl or two in there that maybe you can utilize in your own office or your own practice. So any questions you have, obviously I'll answer today. But this is my contact information. Feel free to reach out. I'm an open book. Whatever I can do to help you, I'd be happy. Thank you very much.
Thank you so much, Brendan. There's already some clapping coming in. You can see that.
Maybe let's see.
Yeah. So if anybody has questions, now's the time to ask them.
You said there's comments on your end?
Yeah, I saw somebody raise their hand and made a clapping emoji.
Oh, it doesn't come through on my end. I don't know if I need to do something.
Okay. Sure. It doesn't look like we have questions so far. Anyone who wants to contact Brendan, that's the contact information for you. Maybe ask something in that. And yeah, then thank you so much for your lecture and your time, for joining us.
Yeah.
Much appreciated.
Thank you. I appreciate you all being here today. It's an honor to be a part of this.
All right. Thank you so much. I think we can go into a lunch and coffee break now if nobody wants to ask the question or follow up on this. All right. Everyone is satisfied, I guess. Okay. Then hope to see you again, Brendan.
Likewise. Thank you so much. Appreciate the opportunity to be here.
Bye.